breast cancer. And it kind of makes sense. You know, the longer we live, the more opportunities there is for genetic damage or known as mutations in the body. And as we age, it's harder for our bodies to repair those DNA damages. So, and that goes for really any cancer, not just breast cancer. But increased age is one of the biggest risk factors associated with developing breast cancer. Obesity, in particular, a BMI, also known as a body mass index. It takes into account how much you weigh as well as your height. You can actually, look up BMI online and put in your height and weight, and it'll calculate it for you. If you've never done that or don't know what yours is, but a BMI higher than 25 is associated with an increased risk of breast cancer. And the reason why that is because fat cells are part of your adipose tissue, also known as fat cells, help produce estrogen in the body. And we know that estrogen, which is a hormone, can increase, that exposure. The more estrogen you have can put you at an increased risk for developing breast cancer. So that is what links obesity to breast cancer development. Alcohol is another risk factor. So, women that have a drink every night or heavy drinkers are increasing their risk. Just to kind of remind people of what defines a drink, people that have a drink at night, like if it's a beer, a 12-ounce beer, that counts as a drink, 5 ounces of wine, or 1.5 ounces of liquor. So I think a lot of times, especially in Western society, both in our libations and also in things that we eat, we often have bigger proportions of portions of food and even our drinks and stuff, and we sometimes forget what an actual definition of a drink is. So just to kind of remind everybody, when I say what one drink amounts to. Also, smoking is, believe it or not, actually not as big of a risk factor as alcohol is, but nonetheless, it is still a risk factor, and it's just a risk factor for many things in life and other cancers. So smoking predisposes you to cell damage, which in turn, genetic mutations, DNA, inability to repair itself, and cancers from all of those etiologies. And then lastly, exposure to estrogen, which we've kind of already hit on a little bit, and its association with obesity. But estrogen in general, especially I bring up this fact because a lot of women, once they hit that menopausal state, will start taking exogenous estrogen, or also known as hormone replacement therapy. You also might hear about people talking about bioidentical hormones. I think those were really big at one point, and some people will still take it, but menopause isn't without its awful sequelae, and so no wonder women want to try and squelch any of those symptoms that they can by taking these hormones. So I don't blame them, but there is a risk to taking them. And so if you're taking what's called combination hormones, which is both estrogen and progesterone, that increases your risk of breast cancer by about 75%. If you're just taking estrogen alone without the progesterone, that's mainly more of a risk factor if you continue taking it after 10 years. So if you've got to take something for, your menopausal symptoms, just to get you by for a few years, 5 years, 10 years, I'd recommend taking one that doesn't have progesterone in it. Just take something with just estrogen. Because when you combine them both, it increases your risk even more for breast cancer. And just to kind of highlight, again, these modifiable risk factors, these are things that we can change by changing our lifestyle, changing the way we eat, changing the way we live. So these are things that you have control over. Unfortunately, we don't have control over our genes and things that were passed down to us, as well as age. We're all going to age. But the things that we can control, we should strive to. And it should be also pointed out that about 85% of breast cancers that occur in women actually occur in women with no family history. So that's the most common type of breast cancer, is the non-hereditary form. Just to kind of talk about hereditary breast cancer for a little bit, though, it can get kind of cumbersome and overwhelming talking about genetics. So I'm just going to kind of highlight a few things because I do think it's important, and it's an important thing to bring awareness to, that it is still a component of breast cancer and the way that in which it can be inherited. It comprises about 5 to 10% of breast cancers. And there's a lot that goes into trying to decide which patients would benefit most from breast cancer. So I'm not surprised that that question, out of all of them, was probably one of the more difficult ones. It's even difficult for providers sometimes to look at those that questionnaire and figure out what's the best thing to do. But I wanted to highlight a few things that would maybe be a little easier to remember, so that if you think that, if one of these things affects you, that you could approach your primary care provider or, OBGYN and say, hey, I think, I might need to be tested, have genetic testing for breast cancer, or at least just talk with a genetic counselor who can tell you.
This is the breast cancer seminar they're doing at USA right now.
Well, I didn't go by.
Oh, I think, okay, we're good. I think somebody might be unmuted. Sorry about that. So just to highlight a few things that might clue you into having a genetic mutation linked to breast cancer. So 5 of those things that I want to highlight are: 1, if you have a first-degree relative. First degree is like, mom, dad, sister, a grandmother. Those would all be first degree. If you have a first-degree relative diagnosed with breast cancer before the age of 50. If there's other cancers in your family besides breast, so it's like, dad had prostate, mom had colon, grandma had ovarian. You start seeing a lot of different cancers within the family. That kind of is a clue that maybe there's something going on there. Another factor is if there's both breast and ovarian cancer on the same side of the family. That's a major risk factor. If any male in the family has ever had breast cancer, because that is so rare and more linked to, male breast cancers are typically linked to a genetic mutation, then that would also be something that you would talk about and probably qualify for genetic testing for. And lastly, if there's a lifetime risk of breast cancer greater than 20%. And so you might be asking, well, how do I know what my lifetime risk of breast cancer is? Typically, this is something that your doctor could help calculate for you. If you've ever had a mammogram, you may have noted that at the bottom of your report that you got, sometimes the radiologist will include on there something called a tyroacusic score. There's many risk calculators out there that calculate your lifetime risk of developing breast cancer. We use them all a little differently, and they all provide a little bit of different information. But basically, there's lots of different factors that go into determining that number, like when you started your period, if you're going through menopause, if you've ever had a breast biopsy, what your breast density is, family history, things like that. And so it kind of culminates all those things together to come up with a percentage of what your lifetime risk could be. So if you calculate that and it's greater than 20%, then you're considered in a higher risk category and would qualify for genetic testing. And then here at the bottom, I just wanted to highlight a couple of genes that are the most prevalent, or the most talked about, both in the medical field as well as in social media, is the BRCA1 and BRCA2 genes. So these genes are the most common genetic mutations that we see linked to breast cancer. And so if you have a mutation in one of these genes, that puts you at an increased risk. And it's something that if you get genetic testing, they can test you for these genes in particular. And again, these mutations may occur in up to 10% of all breast cancers. So a lot of information on this slide. I think it's the most cumbersome out of all of them, but really I just wanted to highlight some things that if you have any of this within your family, it's important to just kind of raise that awareness to your physician so that they can kind of help get you glued into we have a genetics counselor here at Mitchell Cancer Institute named Cassie Gerganis, and she sees people both virtually and in her office. And so if that's something that looks like would be a good option for you, we can certainly get you hooked up with her to undergo that testing, or at least just talk about it. So screening. For women of average risk, we want to start doing screening mammograms around the age of 40, and they are done every year. I think pretty much all of y'all got that question, so that was good. Annually at 40 years. Mammograms, even though they've been around for a while, they are still the best screening tool that we have. Believe it or not, they are the best imaging modality we have to look at breast, to evaluate for breast cancer, and mammograms have been shown time and time again to reduce the risk of mortality from breast cancer by 25 to 30%. So even though we come up with newer mammograms and MRIs and things like that, they're still the best imaging tool that we have, and are still important for women to get every year. I want to highlight breast self-examination. So there's been a lot of controversy over the years about, should women do their own exams at home? Are these valuable? What's the point if you're getting a mammogram? And there's been a lot of confusion around that. What I will say is the American Cancer Society does no longer recommends a breast self-exam as a screening tool. However, they do note that it can still be valuable when used in conjunction with screening mammograms. So as a breast surgeon, I would say that I think the take home is I like my patients to at least have a baseline for what their breasts feel like. Many women have what I call busy breasts, meaning they've got breast cysts, they might have some benign breast masses like a fibroadenoma. And while all these things are benign, sometimes they can feel scary. So knowing what your breasts feel like and getting a good idea that, starting out from a young age, you can at least be clued into when you have a change to your breast exam. And that's the most important thing to be aware of. Because sometimes we do still have patients that will find their own breast cancers, and it's because they did an exam at home. So I think they're still important and they still have a role. And you just have to use that information with other information to look at the big picture. So what is a breast exam? How do you do one? There's several ways you can approach the breast exam. First and foremost, you want to kind of start just looking at the outer appearance of the breast. Stand in front of a mirror, look at what the breasts look like, look at the shape of the breast. You want to look at both of the breasts at the same time so you can compare the two. Look at the size and shape of the breast. In general, women typically have one breast that's a little bit bigger than the other. That's just natural. Pretty much everyone is that way. But I will say, if you notice that one is significantly larger and it didn't used to be like that, that would be a change that you would want to bring to somebody's attention. And so when you're standing in front of the mirror, you want to look at the skin, the color. You want to look at the nipple and what it looks like. You also want to raise your arm up and look under your arm. And then you want to examine your breasts both standing as well as lying down. There can be a difference in the way that the breast tissue feels when you're standing versus when you're lying down. And so you want to just get a good feel for what it feels like in both positions. In this picture, you can kind of see there's a couple different ways. I don't know if y'all can see my little mouse here, but you can feel your breast in kind of a pinwheel, or they call this wedges motion. You can also do up and down, and you can also do circles. You don't have to do all of them. I would just pick one and stick with that one, whichever you're the most comfortable with. I kind of like to do the up and down motion on my patients, just kind of feeling, starting at one end and going to the other. That way you don't miss anything. And as long as you do it the same way every time, that's the most important thing. So what are we looking for? So when you're doing this exam, as I've noted, all breasts can feel very different. Some are lumpy breasts, some just don't have as many lumps, and so knowing what your breast feels like and when there's a change is the most important. But what you want to look for is if there's any visible lumps, not only in the breast, but also in the armpit region. That's why it's important to raise the arm up. If you've ever, had a breast exam performed by your OB-GYN or a breast surgeon, you probably noticed they have you put your arm up over your head when you're laying down. And that's to look at the armpit. And also it brings the breast tissue out from the chest wall a little more so that you can feel things even better. So look for a lump in the armpit, look and feel for a lump in the breast. When looking at your skin in the mirror, you want to see if there's any dimpling or retraction of skin from maybe something inside pulling on it. If there's any swelling in any part of the breast that doesn't look right. There's some swelling, or sometimes there can be what's called a puta orange, or it really kind of looks like an orange peel. If you ever have that appearance where you can really see, the pores really well, kind of has like an orangish reddish tint or something to it because it's swollen from edema, then that's something you'd want to point out to your doctor. Paying attention to the nipple. So some women are just born with inverted nipples, and that's fine. But when it's a concern is when you didn't have inverted nipples and then all of a sudden you do. So that can be an early sign of breast cancer. So any nipple changes or nipple discharge, in particular bloody nipple discharge, would be of concern. Pain in the breast, whether it's focal or diffuse, is also something to note. I will say typically breast pain is not the first thing that patients complain of, and it's usually not associated with breast cancer. Usually breast pain is affiliated with your menses and cycle and the hormones that kind of bring about that breast pain, and it's usually something that can go away or that we can treat. But if it's breast pain that's not going away and doesn't seem to correlate with a cycle, or is new for you, then that's something that you'd want to bring to someone's attention. And then lastly, again, just looking at the skin, if there's any skin irritation, even a rash, especially if it's a rash that you've had treated with either some topical cream or something like that, and it's not going away, or it went away and it came back, that's something you'd want to have somebody look at and maybe potentially do a skin biopsy of to make sure that it's not breast cancer. So moving on to screening mammogram. So, we got our exam. Now we're going to do a mammogram, again, starting at the age of 40 and every year thereafter. Things that we're looking for in a mammogram. So the breast tissue is primarily made up of fat. Fat will show up as kind of the darker or gray area that you see on a mammogram. And while these are just picture depictions, these aren't real mammograms, obviously, they kind of show similar to what we see on mammograms. So the dark area is more of the fat. The white area is things like blood vessels show up white. Some of the breast parenchyma or dense breast tissue itself will show up white, and cancers will show up, a little more white or bright, sometimes as a mass. Other times they can show up in other ways. So benign cysts can also show up on mammograms. And then calcium deposits, also known as calcifications, can be seen on mammogram. You may have even seen a report on a mammogram that says, calcifications noted or patient's calcification stable. What that means is that calcium deposits are made in the breast, and that in and of itself is not necessarily anything worrisome. You can have calcium deposits really anywhere in your body. They can calcium can deposit in your blood vessels and various tissues. But something that the radiologist will pay attention to is if those calcifications are increasing in number over time. So, looking back at your mammograms that you had before, if those calcifications increase in number or if they change in their shape in any way, that can be an early sign that maybe there's a cancer there, and then they would want to biopsy it. But calcium deposits in and of themselves, just for the fact that they're in your breast, is not necessarily a concern for cancer. I also want to bring up the fact that if you get a mammogram at one place and then you go to another place, say you move or you change care somewhere, be sure that your images are transferred to the other place, not just the report. It's really important for radiologists to be able to go back and compare breasts over time, because if you think about breasts and women and the changes that we go through from month to month with cycles and hormones, breasts are changing all the time. And I think that's what lends the breast to being more exposed, if you will, or more vulnerable, if you will, to developing cancers, because the breast cells are constantly undergoing change and transformation, and so there's constantly room for error in terms of developing mutations and cancers within the breast. So just make sure you actually have those images transferred and not just the report, so that people can look back at your baseline images and make sure that nothing's changed. Let's see if there's anything else. Another thing I just want to make sure people know, I think sometimes people are worried about how much radiation they're getting. When we're doing all these workups, mammograms and MRIs and ultrasounds, and mammograms are really have a tiny amount of radiation. It's even less than a standard chest x-ray. So you're really not being exposed to much. And a mammogram, doesn't take very long. It's not much out of your, life in terms of saving your life potentially to come and get a mammogram that takes about 20 minutes. And they're not meant to be painful. I know a lot of people, even a lot of my own family members, have talked about how terrible their mammograms are. And I think it depends a lot on the person doing it. Also, if you've had a lot of breast pain in the past or you have sensitive breasts, then sure, it might hurt a little more, but it's really generally meant to just kind of be discomforting and not excruciatingly painful. So if it is hurting you a lot, maybe ask the technician who's doing it if there's any way they can position you a little differently so it doesn't hurt so much. As you can see, this patient in this picture, they're putting the breast under compression. That helps us to see parts of the breast a little better and helps the rays to go through there, through the dense breast tissue better. And you can see that it captures pretty far back on her chest. So that's another reason why if you ever wonder why they have to pull my breast out so much and get so much of it in there, and it's because we want to make sure we don't miss any of those breast cancers that could be hiding back on that pectoralis muscle or your pec muscles. So that's why we got to get all the breast tissue in there. And unfortunately, that's just the only way to do it. But all in all, they'll get 2 views and then you'll be done. You won't have to do one for another year. So after we've kind of talked a little bit about risks involved and bringing awareness to, what you can do in terms of your part to get your screening mammograms done, I just wanted to talk a little bit about some of the lifestyle modifications that I alluded to early on in regard to reducing your overall risk of developing breast cancer. So we talked about obesity being associated with an increased risk. So if you can try and maintain a healthy weight with a goal BMI of 25 or less, that's going to decrease your risk. Also, exercising regularly, 4 to 7 hours per week. I know sounds like a lot, but if you can just do anything, 30 minutes a day, 3 hours a week, something, you're going to be reducing your risk for breast cancer as well as other, cardiovascular and other comorbidities as well. So the main thing I think you want to do when you exercise is you do want it to have a little bit of some moderate to intense activity in there. You want to get your heart rate up to really have a long-term effect for things like risk reduction. Limiting alcohol intake, we already talked a little bit about that, but less than 3 drinks or 3 drinks or less a week Just keeping it at that, and not trying to, indulging every once in a while, of course, is fine. Everybody's going to do that, but trying to, on a weekly basis, limit that consumption is key. As far as eating healthy, just getting a nutritious diet in. There's so many diet fads and so much misinformation about what we should be eating out there, and I think people really sometimes can be overwhelmed with, should I do South Beach diet? Should I do keto diet? Should I do this? If you just in general try to avoid, excess carbohydrates, excess sugars, and processed foods, that's going to be above and beyond what you need to do in terms of eating healthy, and that goes for anybody. Just trying to limit those things. Again, having the occasional cake or cookie or sweet, there's nothing wrong with that. It's just nothing in excess is pretty much, I think, the take home. And then don't smoke anything. Don't vape. Don't smoke tobacco or cigarette products or any of that. That's going to increase your risk of not just breast cancer, but other breast cancers too. I put some sources on here that I use not only for this talk, but that is also, I think, useful for patients and people to utilize. If you wanted to jot any of these down, they've got great information on things that you can do, and resources and information just to read about breast cancer, and ways to reduce risk, and what happens if they end up finding something, and kind of getting more detail about that and the genetic component of it. If you're interested, these are some good resources and websites to look up. So thank y'all so much for having me. I'm happy to answer any questions now that may have come up, or that you have.
Great. Thank you so much, Rachel, Dr. Hunter. We're going to launch the poll again and have everyone answer those questions who are joining us from Zoom. We'll go over any questions that you all have concerns about, but we'll launch the poll. And then if you have questions, feel free to put them in the chat box, or you are welcome to unmute yourself and ask live. But we just launched the poll, so if everyone could take a few minutes and answer those questions, and we'll go over the results. Great. Thank you, everyone. I see some responses coming in. We really appreciate your participation. We'll give everyone a few more minutes. And apologies for those joining us on Facebook. I don't think you have access to this poll, but next time, if you join from Zoom, you will, but we'll go over the questions as well. And then we'll get to the Q&A. Let's see, looks like we're about 50%. So we'll give it just another 30, 45 seconds. Okay, 60%. Let's see if we can get a few more people to submit their responses, and then we'll share the results. %. That's pretty close. Let's see if we can get to 70. Let's get a couple more people to answer, and then we will close. Okay, we are at 70, so I'll give you guys maybe 5 more seconds. Go ahead and hit submit on any of those you're working on.
Yeah, I'm looking at looking at question 5 now. I don't think I gave y'all enough information to answer that question, so that's my fault.
All right, we'll go ahead and close this out. And yeah, Dr. Hunter, if you want to go through these, we'll share the results. All right.
So number 1, excuse me. So which imaging modality is the best screening tool for breast cancer? So that would be mammogram. As I talked about a lot, mammogram is still the tried and true imaging tool that we use. Now, while we do sometimes use MRI to screen patients, especially those that are not average risk, so if you're considered high risk, you have that greater than 20% lifetime risk, then sure, your doctor may also use MRI as an adjunct, but MRI is never intended to be used to replace the mammogram. It's always kind of an additional imaging tool that can be helpful. Ultrasound is another imaging tool that we use, especially when patients present with something palpable or they have something on the mammogram and they want to see if they can see it on an ultrasound. We also use, but ultrasound by itself is not the best tool to look for breast cancers. And then neither are CT scans. They're not really used at all, except for when we're working at patients for metastatic disease sometimes. What age should women start getting screening mammograms? You pretty much all nailed this one. So 40 years of age is the most recommended age that we should start getting screening, and it should be done annually. Again, if you're in a high risk category, or you had somebody in your family that was diagnosed with breast cancer at an early age, like 40 years old, then by all means, you might start getting your mammograms earlier. For those patients that have a mutation in those genes, such as BRCA1 or BRCA2, they might start getting mammograms more like 35. That's what's recommended for them. But for the general population, 40, and we get them every year. You may have somebody that may say you could do every couple of years. And while that's true, what I would warn people is that, cancers can develop in short periods of time sometimes. I've seen women who have mammograms done, and then 6 months later, they feel something that was not on their mammogram that they had before. And so I think if you are one of those people who your physician says you can do every 2 years, then you want to make sure you don't have a family history, you are doing breast exams frequently, and that your doctor is still seeing you on a regular basis, so that if something were to come up, it wouldn't be missed. But in general, annually is the best approach for getting your breast cancer screening via a mammogram. Which of the following can reduce one's risk of breast cancer? Everybody got this one. So all the above, as we kind of harped on. And then I really did a terrible job of giving y'all the answer for this one. And I think just because I didn't want to make it too complicated, but this question in of itself is always complicated. It's a lot, it's a convoluted question, and the answers can be confusing. So we'll just kind of go through it. So, and again, it's benefit most. Sure, a lot of these people would maybe benefit, but which one would benefit most? So the answer is actually D, which nobody got, but we will talk about why. So in general, when you get a diagnosis of breast cancer, if you are 45 to 50, just having a diagnosis of breast cancer, or let me put it this way, if you're 45 or less, then you automatically qualify for genetic testing because of your age. So with that information, a 65-year-old female who was recently diagnosed with breast cancer, and her mother had ovarian cancer at an unknown age, while it's not insignificant that her mother had ovarian cancer, what I had said, and let me go back to this slide, is if they had both ovarian and breast cancer. So with mom just having ovarian and the female being diagnosed at 65, it's really probably not enough from an insurance standpoint to pay for or qualify for genetic testing. That doesn't mean she might not still benefit, but if we're talking about what we see clinically and what's as far as guidelines go, that would not be something that qualifies. So for a 40-year-old female, and I think something got missed out on this one, or maybe that was my fault. So 40-year-old female, it doesn't say she has breast cancer, so no cancer, but she says that her mother had breast cancer diagnosed at 60. So her mother was young, yes, when she was diagnosed. 60 is young, but it's still not, again, we said if they had cancer before 50. So if she had been a 40-year-old female like our patient in D, or 45, if it had been a 40-year-old female who had been diagnosed with breast cancer and her mother had breast cancer diagnosed at 60, then that would be somebody that we would get genetic testing on. C, a 50-year-old female with breast cancer. So again, she's not 45 or less, she's 50, and she had 2 great-grandmothers diagnosed with breast cancer. So it sounds like a strong family history, but again, a great-grandmother is not a first-degree relative, and so that it's not insignificant, and we still consider it, but in terms of genetic testing, that would not be somebody that we would think right off the bat to send them for testing. A 45-year-old female who was recently diagnosed with breast cancer, but she has no family history, she automatically qualifies for genetic testing just because of her age. Believe it or not, even though she has no family history, because anytime we have patients that present in, very young ages, we think that there could be more of a genetic hereditary link going on. And this also, I think a lot of people forget too, but when we're talking about genetics, genes are passed down through males and females. So it could be that this was something that was passed on to her from her dad's side and just not showing up until it reached a female per se. But there's, so there's various reasons why that sometimes happens, that patients will have no family history, but they'll have a genetic mutation associated with their breast cancer. And then lastly, E, a 35-year-old female with a lifetime risk of 18%. So 18%, yeah, it's creeping up there, but it's not 20% or higher. So she still would not be offered genetic testing at that point. So I hope that clarified it a little bit. I will tell you, genetics is it's an amazing field. It is changing all the time. We have people that literally, go to school just for that. They get master's degrees, highly qualified, like our certified genetic counselor that we have, that have just a plethora of knowledge associated with, not just breast cancer, but she knows about all cancers and genetic mutations associated with them. And it's a lot of information. And that's why even for healthcare providers, that question, I guarantee you a lot of people would get wrong, because there's just strict guidelines and there's various criteria. And so that's why I say, if you have any concern at all or think that you might be somebody that it would benefit, just bring that up, and you can always at least have a visit, visit with a genetics counselor to talk about if you qualify and to discuss the pros and cons of getting genetic testing. Just because you visit with one doesn't mean you have to. So I enjoyed this talk. I hope that you all got something out of it, and that you know a little bit more about breast cancer now.
Thank you, Dr. Hunter. I see a couple of questions in the chat box. Do you want to go ahead and address those?
Yeah, let me see if I can pull those up. I may have to get out of my worry. I'm hesitant to press escape on here.
I'll read them to you. So we have a question from Kim. It says, how important is it for women to use aluminum-free or all-natural deodorant?
That's a good question. So sometimes the residues from deodorants can show up on mammograms. Those aluminum or deposits that they have can show up as that shiny white and be confusing for an abnormality or a mass, or some kind of abnormal appearing lymph node. And so that's why they say don't use it, and none at all. I just wouldn't even put any deodorant on the day that you get your mammogram. Just wait till you have it. You can put it on afterwards. It just will prevent any type of confusion or misconception when doing your images, so that they don't think there's something there, and avoid a bunch of unnecessary workup.
Great, thank you. Let's see, next from Kathy, it says, if you were diagnosed with breast cancer, how important is it to limit soy intake? She keeps seeing different things about this and she's confused.
Limiting soy intake.
Mhm.
I've not heard anything in particular regarding soy. I think, the most important take home I've for not just breast cancer, but any cancers, is just limiting sugar intake. So if the soy product has any type of carbohydrates or sugar in it whatsoever, and sometimes you have to be careful. A lot of things will label and say that they don't contain sugars, or 0% added or something, but look on the back at the nutrition label. If it has any in there, it'll say how much sugars it has. And so I think that's the most important thing that I've heard about in terms of not just reducing risk, but also when patients get diagnosed with breast cancer, trying to limit that in regard to preventing recurrence. But that's a good question, and I would have to look a little bit more into soy to give you an exact answer about that.
Okay, let's see. We've got one here. It says, it's a good question from Rebecca. Does hormonal birth control use increase the risk of developing breast cancer?
Using birth control does slightly increase your risk for breast cancer. However, all your OB-GYNs, breast cancer doctors, everybody, there's no reason, it's not enough risk to stop taking it, if that answers your question. I'd say the majority of the patient population and females in general are on birth control to help prevent unnecessary births. What I would say is, when birth control comes into play and when we might tell patients to stop taking it, is if you get a diagnosis of breast cancer, because when that happens, especially if it's a hormone positive breast cancer, and I know we didn't really talk about the different types of breast cancer, but if it is a hormone sensitive breast cancer, then we'd want to stop any exogenous hormones at that time. And so you could switch to, there are non-hormonal like IUDs that you can get. There's, like a copper one out there, and there's probably some other ones out there. But just taking birth control pills in and of itself is generally, especially if you don't have a big history of breast cancer in your family, I would say don't stop taking those because of that. It's just not a high enough risk to warrant not taking your birth control.
Great, thank you for that. I don't see any more in the chat box. If anyone has any other questions, feel free to submit them, or you are welcome to unmute yourself and ask live. Lindsay, do you see any questions on Facebook? I didn't know if anyone had submitted any on Facebook that we need to address.
No, that was it.
Okay, great. Well, if there are no more questions, I think we can wrap this up. Thank you so much, Dr. Hunter. This was a great presentation, and thanks everyone for joining us. We hope that this was educational and informative.
Thank y'all for having me. Really appreciate it.
All righty.